Assalamu alaikum. Good morning, good afternoon, and good evening. I hope everybody is doing great. And today we are gonna cover respiratory system physical examination. I hope everybody has the screen. So let's just start it. What is this station is really testing? Very important. The respiratory station rewards structure, safety, comparison, site to site, and concise interpretation. So don't forget. Approach, we all know by now, right? We are starting with introduction, confirming the patient ID, explain the examination, our rules, and obtain consent, and then we start. Safety, assess the stress first, request vital sign. If you don't have it, most likely it will be provided in a door instruction. But if you don't have it, we never start any physical examination without having vital sign. It means that's priority number one. We need to have it. If we don't have it, ask for it. Recognize red flags, techniques, exposure, and positioning of the patient. For this specific examination, the patient can be sitting, can be lying down. It is totally up to you and your patient. Whichever position the patient is comfortable, you can start doing it. But usually for this, they will be already on the edge of the bed and the head of the bed will be 45 degrees. So it means they don't want you to waste adjusting the bed and this and that. Usually everything will be prepared and ready for you to just start. So yeah, so techniques, exposure, positioning, symmetry, and comparison, anterior and posterior. Do not forget about posterior. Some of the IMGs, they get anxious, they just do the anterior, and they completely forget about the posterior auscultation, which that cost you a lot of mark. Interpretation, finding syndrome. Remember, when you're finding any abnormality, you have to verbalize it because you have your stethoscope. You cannot look around and have a proper eye contact with the examiner. You just mention. At this point, I'm noticing wheeze. At this point, I'm noticing cross crackles, fine crackles, this and that, whatever. Or the patient has normal vesicular sounds, right? So I do not appreciate any abnormal sounds at the front side. If there is, the examiner will tell you there is a wheeze positive all over the lung. Or there is, for example, let's say chorus crackle positive in the lower lobe of right side, right? They will verbalize it. Communication, professional wording, patient comfort, clear summary to examiner. Examiner mindset. What is their mindset? Let's say there is an examiner in this station. What do they think? What do they want from you, right? So can this candidate examine a breathless patient in a safe, organized, efficient way and communicate clinically meaningful findings? This is their mindset. First of all, are you able to recognize if the patient is stable or not? Do you know how to approach? And do you know how to communicate or convey the clinical findings professionally? That's all they want from you. So if your patient is having an acute asthma attack, right? So you need to provide them with a rescue medication first, then start the physical examination. I'm not just gonna okay, just give me a few minutes, I'm gonna finish the physical examination, right? So this is what they want to know. Do you know how to act based on the patient's condition? If that's an acute attack, the patient cannot talk, one sentence or one word, forget about the sentence, one word. Are we still continuing the physical examination, right? So this is their expectation from us. Opening, setup, and general inspection. I would like to perform a focused examination on your breathing and chest. It will involve looking, listening, the front and back, and keeping you comfortable throughout. So this is an example. It doesn't have to be exactly this way. You can word it the way you want it. But this is how you need to start, right? The first 20 seconds, what to inspect. Work of the breathing. This is, you have to explain and verbalize it. Like if the patient has tachypnea, the patient has tachypnea. If the patient is using axillary muscle, then I'm going to mention it, verbalizing it, that I notice the patient is having axillary muscle use. Inability to complete the sentence, my patient looks like to be able to speak in a full sentence, or the patient cannot even complete one sentence. Position, upright, tripod, agitated, fatigue, drowsy. My patient is sitting upright position or in tripod position. Upright is good, tripod is bad. My patient is agitated because probably he's agitating from the overdose of the medication that he's using, for example, anticholinergic or whatever, or the patient is agitated because of the asthma attack, right? Is the patient fatigued because lack of oxygen, or the patient is drowsy, about to faint, right? Color and oxygen. Is the patient look cyanotic, paler, sweating? Visible asymmetry, chest movement, chest trachea pull, scars, drain, deformity. Do I see any chest movement symmetrically? Yes. Is it asymmetrically? Probably it could be pneumonia, pneumothorax. It could be pulmonary effusion. It could be anything. Tracheal pull, is it deviated or it looks normal at the middle? By naked eye, because I'm inspecting. I haven't started palpating, but I have to confirm with palpation, right? Do I see any scar, any surgeries at the front, at the side, anywhere? Are you okay, Mr. Jan? A step-by-step exam sequence. End of the bed. General inspection, the stress, speech, position, oxygen, hands and pulse. Remember, clapping is you need to check it for the cardiovascular and also for the respiratory. Cyanosis, tremor, CO2 flapping if relevant, rate, rhythm, volume. For the face and neck, central cyanosis, pursed lip, trachea, axillary muscle, GVP, check if needed. Chest inspection, exposure, symmetry, scar, deformity, respiratory pattern, palpation, percussion, expansion. For the expansion, you can do it from the front, you can do it from the back. No, you can do it either. Yeah. Now it's up to you. You want to do it while the patient is lying down because you can do it at the front. But I prefer to do it from the back because I don't want to like get too close to the patient's face. And it's a little bit uncomfortable if that's a female, right? Because I'm going to go under the breast. So probably she doesn't like it. So again, I let you decide as a human being, as a professional medical doctors, which one is better for you to do it. If you feel that you can do it properly from the front, do it. If not, do it from the back. And if you think that I forgot it and I don't have time, or maybe my patient doesn't like it, or you have already made a mistake and you don't want to hurt the patient again, because that expansion is a little bit uncomfortable because you have to press, right? So anything that cause any discomfort for the patient, we need to avoid. So instead of doing that, I can just put my hands on the chest and ask the patient to take a deep breath in and out. If there is any expansion issues, one side will move, the other side will not move. It's a little bit hard to get it, but if I'm experienced enough to tell, I can do this. And instead of pressing from the sides. Auscultation, anterior, we start with the anterior and posterior field. Voice sounds of focal disease, suspected, then peak, flow, saturation, asymmetry. So for the focal, if there is, let's say, focal finding like consolidation, then we go for the firmitus and so on and so forth for vocals. Other than that, we just skip that. And 99% of the time, they don't want you to do that because it is time consuming. Just to ask the patient to do the 99, 99, 99, 99, it would definitely take 1 minute, which is waste. If any focal finding is positive, then yes. Otherwise, which again, 99% of the time, it will be negative. If you have a local finding, consolidation, dullness, or stony dullness, and the patient says that this part is, for example, the patient have consolidation, let's say, in the lower lobe. Now, then you have to cover the agophony, firmitus, vocals, all of them. And trust me, they're not going to ask you that because that's very time consuming. Only to go check all that will take you 2-3 minutes and you don't have it. Agophony. Yeah. Yeah, they're not going to ask you, trust me. Yeah, golden rules, compare left with the right at the same level. So same level, go down, same side, other side, same level, go one level down, then go to the opposite side, go down one level, then move on to the other side, the opposite side. So the same way that I show you, yeah, like this. So same level, go down, opposite side, go down, opposite side, go down, opposite side, go down, opposite side. Don't go like zigzag. Zigzag is not right. And this is commonly mistaken by MGs. And as soon as you start touching your stethoscope, the examiner will stand up and come looking at how you do it. Yeah, he will stand up and just come right away and take a look at you, how you do and move your stethoscope. If they see you doing the zigzag, then that's going to cost you more. Normal breath sounds. It could be vesicular, soft, low pitch, heard over the most lung field. C, you can say everything was normal or sound was normal, or you can just say the vesicular sounds are appreciated, or you can just say across all the lungs, I found soft, low pitch sounds, which is normal. Bronchial, vesicular, medium pitch, near major bronchi, and bronchial, louder, higher pitch over trachea, mandiburum. The abnormal or adventitious sounds: wheeze, narrowed air, fine crackles, alveolar and interstitial opening, chorus crackles, secretion of fluids, stridor, upper airway emergency. I would auscultate side to side over the anterior and posterior chest, comparing the equivalent areas for air entry and added sounds. This is how you phrase it. If focal disease is suspected, now you can add vocal resonance, bronchophony, agophony to strengthen your interpretation, which normally they don't do it. Now, this is the slide that I love, and I would encourage you guys to pay attention to this slide because it makes your life very easy, okay? Now, high yield abnormal patterns you must recognize. Asthma. The work of breathing is increasing. The patient is using axillary muscle, right? Prolonged expiration. If you're doing an MCQ one, this might be one of the questions. Prolonged expiration, okay? Percussion. Often, if you percuss, the patients will have resonance or hyperresonance, okay? But auscultation, diffuse expiratory wheezing. Air entry may fall if severe. Now, COPD, the patient will have a barrel chest, pursed lips and hyperresonance, quiet chest, wheeze, reduced breathing, sound. Consolidation, reduced expansion vocally. Patient will have dullness and percussion. The patient will have bronchial breathing. Crackles will be positive. Vocal resonance will increase. Vocal resonance will increase. This also might be in the licensing exam, one of the options. For example, for COPD, the patient, for the consolidation, the following findings are accurate. Bronchial breathing, crackles, vocal resonance increased, vocal resonance decreased, vocal resonance is absent, this or that or whatever. So the right answer would be bronchial breathing, crackles, and vocal resonance increased. Pleural effusion, reduced expansion on affected side, obviously, but the difference between consolidation and effusion is the stony dullness, which is positive in pleural effusion. Reduced breathing sounds, vocal resonance goes down. And effusion, vocal resonance is down, and in consolidation, it goes up. Or when you're performing the physical examination and you're at the, let's say at the middle or at the lower lobe, and you're checking everything is normal, and then examiner say, you know what, there's when you did the percussion, there was a dullness, and now there is a vocal resonance decreased. So you know, oh, it is decreased, then it should be pulmonary effusion. So most likely the patient has pulmonary effusion, or the vocal cord, the vocal resonance is increased. So it is consolidation, most probably pneumonia. Sorry? Stony is more dull than dull. It's like stone when you.
Oh, it's like a stone.
Yeah. Pneumothorax, acute asymmetry. Let me finish the lecture. Sorry, it's recording. Pneumothorax, acute asymmetry, distress, hyperresonance, markedly reduced or absent breath sound. Danger phrase: silent chest and severe asthma. Ominous and urgent. Intubate. Red flags and severity, immediate concern, cannot complete a sentence. This is something that we have to ask the patient while to make sure that the patient can finish a sentence. If the patient cannot finish a sentence, obviously we're not going to continue. First, we have to rescue the patient. Silent chest, very poor air entry, central cyanosis, confusion, exhaustion, severe asymmetry, or tracheal shift. That is emergency. Measure and interpretation, respiratory rate and pass, oxygen saturation plus supplemental oxygen, peak flow if appropriate and feasible, trend after treatment if given. Say this to score. This patient appears breathless, but stable enough to continue, right? So you talk to the patient, my name is doctor, like, is it okay if I do this and that? And the patient, yeah, sure, go ahead. Okay, so you know that the patient is comfortably talking. So now you report to the examiner that this patient appears breathless, but stable enough to continue the examination. Given the work of the breathing, I would check the oxygen saturation and be ready to escalate if the patient deteriorates. Never ignore the patients while chasing the perfect routine. How to present your findings to the examiner. For normal examination, what to do? This is a focused respiratory examination with a normal chest expansion, resonance, percussion, and a normal bilateral air entry without added sound. So this is my finding. Now for the asthma, if that is your patient and you know the patient has asthma, now how do you report that? This patient is tachypneic with a prolonged expiration and diffuse bilateral expiratory wheeze, most consistent with acute asthma exacerbation. Now, for the consolidation, how we do it, there's a focal reduced expansion, dial percussion, bronchial breathing, and crackles on the right base, wherever you find it, on the right base, left base, whatever, suggesting consolidation. Pleural effusion, there's a reduced expansion, stony dullness positive, and decreased breathing sounds at the left or right base, wherever you find it, in keeping with the pleural effusion. Finish with severity comment, most likely diagnosed. What would you do to complete the assessment? So what is your next step, right? High frequency mistakes. These are the mistakes that we should be avoiding. Starting the percussion or auscultation before an inspection. We never do that. And they do not expect us to do this, right? Poor exposure or forgetting posterior chest examination. Sometimes we get very anxious and nervous. We just check the front and we totally forget about the back, which is the most important comparing to the front, right? Not comparing left with the right at the same level, doing a zigzag. Don't do the zigzag, go to the same level, then one level down, opposite side. One level down, opposite side. Describe sound vaguely abnormal chest instead of naming them. Like just calling abnormal chest. Like, what do you mean by abnormal chest? Oh, I found wheezing. I found fine crackles. I found this and that. So you need to be able to pinpoint it. Failing to summarize the findings into likely summary syndrome. What examiners love? Calm opening, consent, hand hygiene, and patient comfort. A visible routine that is efficient but adaptable. Correct medical vocabulary like wheezing, crackles, bronchial breathing, or stony dullness. So when you're doing, don't say all this, nothing is wrong with this patient or no abnormal sound. You just need to mention it. I do not appreciate any wheezing, any dullness, any stony dullness, any fine crackles, any cross crackles. They expect you to mention it, not just say everything is normal. Like, what do you mean everything is normal? What were you looking for? So they expect you to mention that these are the abnormal sound that I was looking for, but I can't find any of them. So if you say abnormal, like abnormal could be anything. So what do you mean by that, right? So you're checking, my patient looks fine, and I do not appreciate any, I did not find any abnormal findings or sounds like wheezing, crackles, this. A brief completion plan, vital saturation, peak flow, voice sounds if relevant. Clear one sentence interpretation at the end. The one slide just to summarize all the station, or I mean the whole lecture, or just to wrap it up. Enter. As soon as you enter, you introduce yourself, confirm the patient, date of birth, and name, explain plus obtain consent, position the patient, expose appropriately, then look. Look, first general inspection, then focal inspection or focus inspection, speech and the stress. Check for that. Very important. If you're dealing with the respiratory, you have to check for the speech. And then mention that my patient looks breathless, but he's stable enough to continue with the physical examination. This is what they expect you to know. Like, do you know that this patient can continue the physical examination, or you just have to do it regardless, right? I have to verbalize it to the examiner that he is breathless, but he's stable enough to continue the examination. Respiratory rate, oxygen saturation, chest symmetry. Now feel hands and pulse. Hands and pulse, we check for the hands, check for the pulse, and once we are done with the pulse, then we move on to the face, then the neck, trachea, chest expansion, percuss side to side. Listen anterior, then posterior, air entry and added sound, voice sounds, a focal disease suspected, compare equivalent area. Thank the patient, state the key finding, give likely diagnosis. So say what you would like to complete. And best practice drill, rehearse this sequence aloud until the sounds natural, not memorized. So you keep on doing it as much as possible so that nobody can tell that you completely memorized the whole whole station, right? Some of the part you can like memorize. Like at the beginning, you can memorize the whole thing. Like, hello, my name is Dr. Muhammad. I'm one of the doctor, and due to today I'm tasked to come here and perform a physical examination. I hope that's okay with you. You can memorize it, but the whole station that we this, you cannot memorize it. But some of the part that you need to like introduce and the first impression that you need to do and put on the examiner, please do that. Memorize it, change the name, change the station, that's it. As long as you feel sound very professional and you sound very fluent, that's more than enough. Then how you're going to deal the rest, it will be very easy. If the first and beginning is strong, you can always finish it strong. If you come weak at the beginning, trust me, the ending will be weak as well. Okay?